Hello everybody. At the outset, I would like to thank the organizers, Dr. Deepak Govind sir and Dr. Anand, for inviting me to the 11th annual Critical Care Refresher course. I'll be talking about a patient with extremely high blood pressure with or without organ failure. So I'll be starting one or two cases which we received in the last few weeks. So 42-year-old male, known hypertensive on multiple antihypertensives, known CKD, baseline creatinine of 6.5, a mild COVID history in 2020, and he presented to the casualty with complaints of progressive shortness of breath for one day. On examination, his blood pressure was 210 by 150, saturation of 88%, respiratory rate of 30, and he had bilateral creps on auscultation. He was started on NIV support, managed with diuretics, NTG infusion was started, and he was already given oral clonidine, nifedipine, sublingual, and amlodipine in the emergency. He was shifted to the ICU, to NIV support in the ICU, persistent hypertension NTG infusion, had to give labetalol also intermittently and then on infusion, and he improved over time with dialysis. A second case, a 62-year-old female, diabetic, hypertensive, CKD, and hypothyroid. Known case of obstructive sleep apnea, presented with the casualty complaints of inability to speak, inability to get up from the bed, altered behavioral pattern, had a BP of 230 by 108, on ICU admission was conscious but had delayed response to verbal stimulus, reduced power and slurred speech. Stroke protocol was activated and MRI brain suggestive of small Lachman impact was found. Labetalol had to be given for blood pressure control and started on infusion subsequently. Fundoscopy done, no evidence of papilledema, it was showing hypertensive retinopathy and further evaluation was done. So these are two very common cases that we see day in and day out. Patients having an old history of diabetes hypertension, presenting with hypertensive failures. So what do exactly do? So the topic now I'm going to, you must have faced so many of these cases in the recent times in your critical care experience. So what exactly is hypertensive emergency? So the latest definition in 2019 in the European Society was given. Severe increase in blood pressure associated with acute hypertension mediated organ damage. So they've given this term acute hypertension mediated organ damage to the heart, brain, retina, kidneys and large arteries. As far as nomenclature goes, the systolic blood pressure is more than 180 and the diastolic of more than 120 is taken as hypertensive emergencies. However, lower thresholds can be associated if there is a swift elevation from lower baseline blood pressure. And remaining situations with elevated blood pressure but without this end organ damage called as AHMOD is named severe uncontrolled hypertension. So these are some of the common examples of end organ damage which we actually see, and if you actually count them, they'll be having a decent number of admissions in all ICUs. Subarachnoid hemorrhage, hypertensive encephalopathy, ICH, ischemic stroke, acute aortic syndrome, coronary syndromes, pulmonary edema, severe preeclampsia and eclampsia, pheochromocytoma, renal failure, and malignant hypertension. So it is very important to distinguish between hypertensive emergencies and uncontrolled hypertension because the management is totally different. So patient presenting with hypertensive emergency, and remember emergency, if you say a patient is having an end organ damage, ideally treated by pharmacological and non-pharmacological interventions. Remember, you have to admit these patients in the intensive care unit. Usually they require intravenous drugs, and depending on the organ system that is being involved, which is having end organ damage, you have to devise specific treatment protocols and guidelines and target blood pressure. Whereas an uncontrolled hypertension usually does not have end organ damage and hence does not require admission in ICU and sometimes can be managed on OPD basis only. They are usually on antihypertensive medications which they have missed, and we have to just modify, reconstitute or intensify the antihypertensive treatment in these patients. Remember, the most common predisposing factor is low adherence to the antihypertensive drug therapy or discontinuation of BP lowering drugs. In the Western world, it has been found that abuse of illicit substances and recreational drugs, especially cocaine, has been one of the common causes. And poor control of common risk factors are usually seen in these patients like smoking, obesity, hypercholesterolemia, and diabetes mellitus. So what is the way to manage these patients? A patient having possible hypertensive emergency and then is having blood pressure of more than 180, 110, 120, these are all, there's nothing sacrosanct about these values. Give different guidelines, give different values, but one thing is very common, they are associated with end organ damage. So they have symptoms related to either CNS, kidney, cardiopulmonary system, or a pregnant patient having preeclampsia or eclampsia. So basic subset of tests have to be done, which includes the complete blood count, platelet count including creatinine, potassium, haptoglobin when you suspect renal failure with thrombotic microangiopathy, ECG and fundoscopy. And then some particular tests depending on the organ systems involved. So if you are suspecting a ACS, a cardiovascular thing, you can have to go with troponins, echocardiography. In case of aortic syndromes, CT angiography sometimes. Acute ischemic stroke, you need to have the stroke protocol, a CT scan if it is not possible to do, and if it's not diagnostic, probably you do have to have an MRI. If he's in the window period, then you have to treat him accordingly and control the blood pressure before treating him accordingly. Preeclampsia, eclampsia, we have to focus more on liver function tests and uric acid. And if you have a thrombotic microangiopathy, the treatment is slightly different. Quantitative urinalysis for protein, urine sediments, renal ultrasound, and peripheral blood smear. So the workup should also include a history and an examination. History of pre-existing hypertension, their medications, whether they are taking it regularly or not, and illicit drugs. And blood pressure examination should be done in both supine and standing positions as well as in both arms. And we should actively seek signs and symptoms of end organ damage. So I will be repeating many times about this end organ damage, because the thing is, if you control the blood pressure here in a decent manner, the changes are mostly reversible and the patients are salvageable. So patients, these are three different presentations, and that is why the emphasis is there. Specific investigations should be based on symptoms and aligned with each associated condition. Differential diagnosis. So patient presented with altered mental status of BP of more than 220 by 120, you can need a brain imaging, and if the imaging CT scan is non-diagnostic, you may have need a MRI. A shortness of breath patient may have to be evaluated for cardiac symptoms like troponin and natriuretic peptides, and a CT for acute aortic syndrome is suspected. Again, summarizing till now. So what are the management principles in these patients? So preventing the occurrence of hypertensive emergencies should be as important as the treatment, although we are all critical care physicians. But if we can prevent these in our locality, friends, families, and I suppose many intensivists will now be practicing physicians soon, we should be able to avoid many of these hypertensive emergencies. Remember, there is a lack of evidence from RCTs to establish the best therapeutic approach or the optimal drug. And BP reduction should be obtained gradually in a controlled manner without compromising organ function. So there is no sacrosanct drug in most of the cases, and BP reduction should be in a gradual manner. These are the common things to prevent the hypertensive emergencies: salt restriction, cessation of smoking, decreased alcohol, physical activity, healthy balanced diet. We all know about that, but finally not many practice them. So patients presented with hypertensive emergency should be admitted to ICU for close monitoring, and target here is not to achieve a particular BP value. Target is to preserve the organ perfusion and to prevent hypertensive target organ injury. And comorbidities and target organ involvement influence medical decisions. So you should know the end organ damage, the drug that you are using, the side effects, the doses, and preferably you should have a chart to guide you what are the targets. IV medications in the ICU are preferred because of fast onset, able to titrate, and a shorter half-life. A general goal should be lowering blood pressure in a controlled manner with a systolic blood pressure reduction of more than 25% in the first hour, followed by gradual reduction to 160 of 100 within the next 2 to 6 hours, and then over the next 48 hours decreasing it further. Exceptions are there like aortic dissection, preeclampsia, and pheochromocytoma, which require rapid BP reduction, whereas other approaches require less aggressive ones like ischemic stroke. So we are all aware of this central concept of autoregulation, which ensures that the organs and tissues receive constant blood flow across a wide range of arterial blood pressures and has been defined from 50 to 150 millimeters of mercury. This is critically important for high flow, low resistance organs such as brain and kidney. So if you decrease it too quickly, it has got its own side effects. So hence we prefer a slower stepwise reduction in blood pressure beyond the lower limits of autoregulation. And these are the exceptions in detail. I will be talking about each of them in more details later on. So remember, these are the drug charts. These are commonly used drugs. Can I have an audience poll of what drugs that you use in hypertensive emergencies? NTG. And anything else? So if you read the literature, the Western literature, there's nicardipine has been used quite often. clevidipine has come over, but I have talked to many, after I was given this talk, I talked to more cardiologists, more intensivists, but I found that even all of them use NTG and labetalol only still. So at least we should know these drugs in and out. Yeah, so these are 3 studies which are ranging from 2008-2013 where they found that nicardipine is a very useful drug. But frankly, none of us has an experience using it. So here are the targets and here are the commonly used agents. Is the slide visible? I have taken it from an article. So acute coronary syndrome. So just remember that every organ system when there, I'll give you the PPT. That's not an issue. So every organ system has different or target blood pressures. And if you know the rough range of around 15-20% in the first 1 or 2 hours, that will suffice. So in basically in neurological emergencies, we will use labetalol, whereas in cardiovascular emergencies, we use nitroglycerin. In acute aortic syndromes, we need an immediate plus a titratable blood pressure decrease. So then we use esmolol plus nitroglycerin. So if you in preeclampsia, labetalol and nicardipine are the agents of choice. So I'll be talking about a few specific conditions just to go in detail. One slide about each or maybe 2. So hypertensive encephalopathy. We commonly encounter this in our critical care units. You must have encountered it. A patient having neurological symptoms with just an increase in blood pressure, having confusion, seizures, maybe some transient focal neurological symptoms and visual disturbances. And when you do imaging, nothing comes out actually. So in these patients, another subset is what we call as posterior reversible encephalopathy. So again the patient is having headache, seizures, altered consciousness, maybe some visual disturbances, and when we do MRI we find a diagnosis of posterior reversible encephalopathy syndrome. So again the cornerstone is controlled and gradual decrease in blood pressure, and initial management should be aimed at lowering the mean arterial blood pressure by 20-25%. So different guidelines say 15-20% the first 1 or 2 hours, some say 20-25%. Again it has to be individualized. The best part about it that it is completely reversible, appropriate initial and optimal treatment with a BP lowering agent completely reverses this diagnosis over the time span of few days to weeks. The drug of choice is labetalol as it is in more neurological things. Now acute ischemic stroke, increased blood pressure can be beneficial as a compensatory physiological regulation to inadequate localized cerebral perfusion pressure while increasing cerebral hemorrhagic risk. Whereas reducing the cerebral perfusion pressure could lead to expansion of infarction zone. So in sometimes we actually allow a higher target blood pressure to avoid this sudden reduction in the cerebral perfusion pressure, especially near the infarction zone than in it. So there are 2 subsets of patients in which we do thrombolysis and which we don't do thrombolysis. So patients with suspected ischemic stroke who are eligible for thrombolysis must benefit for a rapid reduction to less than 185/100 and further maintenance of at least 24 hours to reduce the risk of intracranial hemorrhage. There are 2 guidelines. AHA says a different guidelines, European Society has a slightly different guidelines, but they again 180/110 and 185/100 just varies with this. Again they've preferred nicardipine and labetalol. In patients who are not eligible for thrombolysis or a thrombectomy in an increased window of 12 hours, we maintain higher blood pressure around about to even as high as 220 to 120 to maintain the cerebral perfusion to prevent reversible ischemia. So again these should be monitored in the ICU settings with the arterial line in situ, and in the first 24 hours a gradual reduction of 15% can be safe, and over the next 24 to 48 hours further reduction can be done. Guidelines are even more patchy with acute intracranial hemorrhage, and they say that if you have to decrease to less than 180 but make it more than 140. The agent should be titratable, labetalol, clevidipine, nicardipine, and a newer agent upradipil, but even I don't have any experience with any of them except labetalol. The aim in acute coronary syndrome is decreasing left ventricle preload and afterload while maintaining a low heart rate to prevent adequate diastolic filling time and decrease myocardial oxygen demand. So how do you treat it? Administration of intravenous nitroglycerin up-titrated for controlling the angina while rapidly lowering the systolic blood pressure to less than 140, and along with NTG you may use intravenous beta blockers. If beta blockers are contraindicated, you can go with calcium channel blockers like diltiazem or verapamil, but usually we use beta blockers as well as NTG. Now acute cardiogenic pulmonary edema. The immediate goals here is reducing the afterload, improving the LV ejection fraction and resolving the lung congestion. And the optimal treatment, so this is probably the only case where this documented guidelines say that we use a loop diuretic. Although it's being used much more commonly in hypertensive emergencies, mostly when the patient presents in the casualty, in the emergency, he's already received a loop diuretic if he has a hypertension. But according to the guidelines, is one of the few places in which we actually use a loop diuretic. A mineralocorticoid receptor antagonist can be combined to prevent hypokalemia. NIV will help out. Beta blockers are contraindicated. Then acute aortic syndrome. Remember, it's a life-threatening condition with a very high mortality risk. And the optimal treatment for type A is surgery, whereas type B can be medically managed. Medical therapy consists of controlling chest pain and rapid lowering of systolic blood pressure to 100 and 120. Here is one of the cases where we actually need a rapid titration, rapid reduction in the blood pressure, that is the heart rate. The aim is to decrease the aortic wall shear stress and minimize the tendency of the dissection to propagate. Intravenous beta blockers are the drug of choice in this situation, and commonly used is intravenous labetalol, which is a non-selective beta blocker with alpha and beta adrenergic blocking properties. Esmolol is sometimes favored because of its short half-life. This is a complete different talk. Hypertensive emergencies along with the thrombotic microangiopathy, they try and mimic what we commonly see as TTP and the HUS, whereas TTP and HUS have a specific treatment like plasma exchange and different drugs. But hypertensive emergencies along with thrombotic microangiopathy, the first line management of hypertensive is labetalol and nicardipine. Eclampsia, management requires a rapid initial lowering of systolic blood pressure to a range of 140 to 150 and a diastolic to 90 to 100. Again, the medical therapy relies on intravenous labetalol. This is a place again nifedipine has been used and still being used by many obstetricians. It may cause a sudden fall in blood pressure. And here if we use any drugs which cause bradycardia, we have to monitor the fetal heart rate. Remember, there are many drugs which are contraindicated in pregnancy because of teratogenic effects like angiotensin converting enzyme inhibitors, ARBs, direct ending inhibitors, and sodium nitroprusside. Pheochromocytoma, again a very specific thing. Here we use alpha-1 blocking agents like phentolamine and doxorubicin, usually followed by a beta blocker to target the control of blood pressure. The order should be alpha blocking agents and then the beta blockers to avoid enhanced alpha-1 mediated vasoconstriction. And labetalol is one of the agents which has almost both the properties. Then there are two subsets which I would like to discuss, each one slide. Now, this is a new thing that's coming up, acute peri-op hypertension and post-op hypertension. So they found that if you don't actually treat these things, they may lead to, again, end organ damages. So what are the causes? Adrenergic stimulation, post-operative pain, anxiety and fluctuating intravascular volume. They can actually add up to a perioperative hypertensive emergency. And if the blood pressure is increasing to 180 to 110, you have to intensify the treatment. But here it is a peri-op thing or maybe a post-op thing. So every individual case has to be taken on a case-to-case basis. Then in each patient of hypertension, you should do a fundoscopy examination. You might find a grade 3 or a grade 4 retinopathy. And remember, in these patients, if you find grade 3 or grade 4 retinopathy and he is not having any major organ damage, you have actually found the patient early. Because usually these advanced forms of hypertensive retinopathy are associated with worse cerebral and cardiovascular outcome. So, if you do a fundoscopy in all hypertensive patients and catch them early, it will be of great benefit to them to control the blood pressure and to avoid hypertensive emergencies. Again, this is a table, I think you should each have a table of hypertensive emergencies as a pocket handbook of 4 sides. What are the history you need to take, what are the investigation you need to send according to end organ damage, what are the 2 commonly used drugs, their doses. So suppose you have a patient of hypertensive crisis and you have a blood pressure of systolic of more than 180 and diastolic of more than 120 and he is symptomatic, basic symptoms, and then you send initial workup and then you find that he is having an end organ damage, so he goes into hypertensive emergencies. But suppose he is not having an end organ damage, he goes into a uncontrolled hypertension or just a hypertensive urgency. So they can actually manage an outpatient therapy or just admission in the ward sometimes. But if he has hypertensive emergency, depending on the end organ damage, you have to identify how quickly you need to decrease the blood pressure, which agents are preferred in different parts. And remember, there are some exceptions like acute aortic dissection, which you need to decrease the blood pressure and the heart rate immediately. Again, the targets and the treatment should be at the bedside, ideally. So 1 or 2 MCQs to test you. So identify the correct statements, and here you'll have to tell me. A, you can read it out or I can read out for you. Hypertensive retinopathy is a common finding at fundoscopy and is an important predictor of systemic morbidity and mortality due to hypertensive mediated organ damage. Is it true or false? True. In treatment of eclampsia, ACE inhibitors, ARBs, sodium oxide are contraindicated. True or false? The optimum treatment for type A aortic dissection can be medically treated, and whereas type B is surgery. True or false? False. Great. Diuretics should be used as first line in all hypertension emergencies? False. Great. Again, regarding hypertension emergencies, which of the following are correct? Hypertensive emergency is a severely elevated blood pressure with no signs or symptoms of target organ damage. False. Hypertensive emergency may occur in pregnant women and is a leading cause of maternal death. False. It's not the leading cause. It is frequently attributable to aortic dissection which needs rapid control of blood pressure. So not all cases are frequently attributed. It's a very rare cause, but it is a life-threatening cause. When caused by acute LVF and pulmonary edema, hypertension emergency may be treated by beta blocker. False. So all are false. So match the following. So these are 5 drugs and the mechanism of action. Can you match them? So esmolol out of these 5. Okay, labetalol, NTG, clonidine, again we will be using it very commonly nowadays. Imidazolone alpha 2. Phentolamine. Yeah. So again this is the table, these are the correct answers. So esmolol is a cardioselective beta 1 blocker, labetalol is a non-selective alpha 1 and beta adrenergic blocker. NTG is a nitric oxide donor, and clonidine is agonist of both imidazoline and alpha 2 adrenergic receptors. Phentolamine is a non-selective alpha adrenergic blocker. Thank you. Any questions? Yeah, please.
What would be the advantage of nicardipine over labetalol?
So they compared labetalol, they were decreasing side effects, better titratable control, and there have been studies from 2018 to 13, and there is direct comparison between nicardipine, labetalol, and majorly in neurological patients, and they found it to be better agent as compared to side effects and titration of blood pressure. But I don't have an experience, and I asked many people, they also don't have an experience. So anybody, if you have experience, you can share with me. I'll be happy. Yeah. Anything else? Thank you so much.
Thank you so much, sir.